Hi all, welcome to RAAONLINE. Today we are going to look at a very important topic for any anesthesiologist, that is airway assessment. The first important goal for any anesthesiologist in case of any eventuality or something is you have to secure the airway. So you should have a proper assessment of the airway done in the preoperative period. Thorough and complete airway assessment is essential for any patient requiring airway management. Here the adjective is very important. It should be thorough and complete. The airway assessment should be thorough and complete. Again, I am stressing it. It should be complete. It should be never incomplete, and it should be thoroughly done. The first foremost thing which we do in the preoperative period is get a good airway specific history. You should be able to detect any problem related to the airway like snoring or bronchospasm. Next is a physical examination of the airway. This is done with several simple quick method. This includes Mallampati classification, your thyromental distance, head and neck movement, your body mass index, buck teeth, interincisor gap, and upper lip biting test. This lecture will deal with airway specific history, physical examination with the consideration that all airways are difficult, clinical relevant anatomical structures in the airway, and method of airway assessment incorporating technical advancement as clinically indicated. Now coming to the indication of airway assessment, where you do an airway assessment. Any patient requiring airway management, being it anesthesia, surgery, trauma care or critical care, you have to assess the airway. Patient in respiratory distress or failure, patient with altered mental status like anxious, confused, obtunded, patient with suspected airway compromise, patient who are at risk of aspiration. These are all the indication for airway assessment. Now coming to airway management. What are they? Various indication for airway management. For maintaining the patent airway, being in anesthesia or surgery, failure to oxygenate and failure to ventilate. These are all the indication for airway management. And this airway management can be done in a non-invasive way or an invasive way. Coming to non-invasive airway management, it can be bag mask ventilation or a supraglottic airway, passive oxygenation, or non-invasive positive pressure ventilation. Coming to invasive airway management, it can be endotracheal intubation, cricothyroidectomy, or tracheostomy. Now coming to the first part, airway specific history. You should ask in such a way whether any previous airway problem was there, any nasal obstruction or snoring, any difficulty in breathing. Those points you should stress during history. Disease associated with difficult airway. It can be a congenital like various syndromes, Pierre-Robin syndrome or congenital laryngomalacia, or an acquired disease which can compromise the airway like rheumatoid arthritis, airway surgery, radiation or tumor. Pulmonary pathologies like asthma, pneumonia and COPD, where your hypoxia sets in early and securing the airway will be a top priority. You have to secure the airway as early as possible in this condition, otherwise hypoxia sets in. Another important history which you should ask is patient cardiovascular status. If your cardiovascular status is compromised, the airway securing should be done as soon as possible. Otherwise, it can lead to lot of hemodynamic disturbances. And you should ask for the reason for airway management, what surgery is coming for and what approach you are going to use and what type of anesthesia you are going to use for that particular surgery. You should look at the ample history, that is allergy, medication, past medical history, last meal and any event happening. Functional capacity of the patient, exercise capacity is very important, smoking history, and whether any airway compromise was there, any upper airway obstruction like stridor, hoarse voice, orthopnea, drooling and dysphagia. Risk factors, suspected airway burn, radiation to the neck and neck trauma. These are all the various aspects you should concentrate on history with regard to airway management. Now coming to chart review. The patient might have undergone some anesthesia before, so you should look at the chart. You should look at the previous anesthetics administered and what the surgery the patient has undergone any difficulty with mask ventilation or laryngoscopy is documented in the chart. And if intubation was difficult, what is the reason for difficult intubation? Like any tumor, airway tumor, infection, trauma to the neck phase, or respiratory failure. Severe intubation grade, Cormack Lehane grade, I will explain that later, and maneuvers which was done to improve the view glottis in case it was a difficult viewing of the glottis. And coming to the physical examination, you look at the level of consciousness, cooperation of the patient, body mass index, and in the face you look for beard and craniofacial deformity. Now look at the normal inspiration. Okay, you have the chest, abdomen and the diaphragm. Okay, as the air goes in, okay, now you are going to breathe in, the chest rises and the abdomen rises. Both rises simultaneously and the diaphragm descends. This is when happen with open airway. Now there is an obstruction in the airway. Let us see what happens. Your chest is drawn in and the abdomen goes up. So abdomen goes up and the chest drawn in, there is a paradoxical respiration and the diaphragm is pushed too far in. So this is called the paradoxical respiration with obstruction. Your chest is drawn in, the abdomen moves out. Here both moves simultaneously outwards and the descent of the diaphragm is too much. This happens when there is an obstructed airway. By looking at the breathing pattern, you can say the patient has obstruction in the airway or not, which is called the seesaw respiration or paradoxical respiration. And coming to airway assessment, you look at the mouth opening, you visualize the tongue and posterior pharynx, the distance between the mentum and the hyoid bone, that is mentohyoid distance, and look at the mandible, whether it is small, large or retracted, which has implication during laryngoscopy, your Mallampati classification system. Coming to predictive scoring, you look at the Mallampati score, Thyromental distance, Sternomental distance and neck mobility. Coming to mouth, the first one is you see the mouth opening. If it is greater than 3 cm it is good. If it is less than 3 cm it is bad. You look at the shape of palate, hard palate and sharp palate, whether it is high arc or low arch. Then you look at the uvula, whether the full uvula is visible or not. You look at the tongue, compare the size of the tongue to the oral cavity, your tonsil. And you look at the anterior pillar, which is a palatoglossal fold, and the posterior pillar, which is a palatopharyngeal fold. Then you look at all the teeth. So with the mouth, you look at the interincisor distance, tongue, tonsils, uvula, hard and soft palate, the teeth and the tonsillar pillars. Now coming to mentohyoid distance. This is the hyoid bone and this is the mentum, and you calculate the distance between the anterior tip of the mandible to the anterior neck of the hyoid bone. This is called the mentohyoid distance. Usually it is greater than 3 fingers. If it is greater than 3 fingers, it is a favorable anatomy for intubation. Next comes the thyromental distance. This is the thyroid cartilage and this is the mentum, upper border of the thyroid cartilage to the tip of the jaw. If it is greater than 6.5 cm, it is normal. Between 6 to 6.5 cm, there is going to be increasing difficulty. And if it is less than 6 cm, it is highly difficult. That is thyromental distance, which is called Patel distance. Now coming to the sternomental distance, from the sternum to the upper border of the sternal notch. If it is less than 12.5 cm, it indicates difficult laryngoscopy. Sternomental distance is known as the Savva distance. Now coming to the 3-3-2 rule, interincisor gap 3 fingers and the mentohyoid again 3 fingers and the thyrohyoid distance, which is 2 fingers. This is called the 3-3-2 rule. 3 fingers in the interincisor, 3 fingers in the mentohyoid and 2 fingers between the thyroid and the hyoid bone. So coming to, with these 3 parameters, how will you predict difficult laryngoscopy? Mouth opening less than 5 cm or 3 fingers depth, that is a distance from thyroid notch to chin is less than 6.5 cm, and with the 3-3-2 rule, the distance less than 3-3-2 finger breadth, also going to predict the difficult laryngoscopy. Now coming to teeth. If it is edentulous, your ventilation is going to be difficult. Also, you need some gauze of pad placed over the mask for ventilation. You look at the teeth prominence. If the incisor is prominent, the introduced laryngoscopy, it is going to be difficult. And the relationship of the maxillary and the mandibular incisor during jaw closure, and the presence of denture and loose tooth is another important part. You have to look at the preoperative air assessment. And if denture is in place, you should leave the denture in place because ventilation will be difficult without dentures. And you can remove the dentures after laryngoscopy and securing the airway. And the status of the teeth is very, very important. All the 32 teeth should be numbered. You have to look at the 4 quadrant: upper right, upper left, lower right and the lower left. And you have to look at the premolar, canine, incisor and the molars. The dentition should be assessed, and as I said earlier, while dentures can be removed for intubation, they are left in place for non-invasive airway management, particularly bag mask ventilation. Now coming to the most important part of the airway, the neck. You have to look at the range of motion for the head and neck, the neck circumference and the neck length, compliance of the mandibular space, sternomental and thyromental distance. And always don't forget in the preoperative period to look from the side view of the airway, particularly the neck. Here you can see the front of neck axis. This is the thyroid cartilage and this is the cricoid cartilage, and you have the tracheal ring, and here you can see the cricothyroid muscle, and this is the cricothyroid membrane which plays a very big role in cricothyroidectomy. These are all the front of neck axis: thyroid cartilage, cricoid cartilage, tracheal ring, cricothyroid membrane and cricothyroid muscle. This cricoid cartilage is very, very important for cricoid pressure, and tracheal ring for tracheostomy, and cricothyroid membrane in case of emergency cricothyroidectomy when you are not able to secure the airway. And in the neck, you have to look for the movement of cervical flexion and Atlanto occipital extension. Front of neck axis, as I said earlier, cricothyroid membrane, tracheal ring and cricoid cartilage. This is for cricoid pressure, tracheostomy, and this is for emergency cricothyroidectomy. And you have to examine the neck for infection, burns, radiotherapy, surgical scarring and any mass. The thyroid might have a huge swelling and you have to look for the neck mass. And coming to what is called as Delilkan sign. Here you check the movement of occiput over the atlas. Okay, you place the right index finger on the occiput and the left index finger on the chin. Okay, here you look at the level of the right and the left index finger of the anesthesiologist. Normally, the right index finger will be lower than the left index finger. That is normal. If your right index finger and the left index finger are at the equal level, it is going to be difficult laryngoscopy. If the right index finger is going to be higher than the left, or the left index finger lower than the right, it is going to be extremely difficult laryngoscopy. Now coming to the mobility of the neck. Mobility of the neck plays a major role in securing the airway. The ideal position for intubation is called the sniffing position, where all your pharyngeal, laryngeal and oral axis fall in a single line. In sniffing position, there is a neck flexion of 35 degrees and a head extension of 15 degrees. Neck immobility interferes with aligning the pharyngeal, oral and laryngeal axis. All these three axes should be fall in plane to secure the airway. Neck mobility can be impeded by cervical collar or structural changes including fracture, dislocation or arthritis, where your neck mobility can be altered. Here, what is by sniffing position is there should be 35 degrees neck flexion and 15 degrees head extension at the Atlanto occipital joint. This is the sniffing position. By doing this, you align all the three axes together. Coming to Atlantal occipital extension, you have to assess the Atlanto occipital extension. In case there is no concern for cervical spine injury, your extension can be assessed. But if there is concern about cervical spine injury, the cervical alignment is maintained during intubation, which might lead to difficult intubation. Your extension is limited. You cannot extend because the patient is having cervical spine. Here the intubation can be difficult. Now coming to the movement of Atlanto occipital extension, it can be up to 35 to 50 degrees and it can be classified into 4 grades. In grade 1, there is no reduction of Atlanto occipital extension. In grade 2, there is 1/3 reduction. In grade 3, there is 2/3 reduction, and grade 4, there is no movement at all. There is no appreciable extension. There is complete reduction of Atlanto occipital reduction. That is grade 4. Coming to neck mobility, okay. Here you can see the neck extension. Normally it is around 60 degrees. You can extend the neck. Coming to neck flexion, it is about 50 degrees, okay. The flexion is 50 and the extension is around 60 degrees. And coming to head bending laterally, okay, you can bend laterally up to 45 degrees towards the right or the left. You can bend around 45 degrees. Coming to rotation of the head, the right rotation can be around 80 and the left rotation can be around 80 degrees, okay. You have flexion, extension, lateral movement and the head rotation. The extension is around 60 degrees, the flexion is around 50 degrees and the lateral bending of the neck is around 45 degrees and the neck rotation is around 80 degrees. These are all the normal neck movements, about how much degree the neck can move. Now coming to the sniffing portion, which is the most important portion for the intubation. You place a headrest which is approximately 10 to 15 degrees. By this, you provide 15 degrees extension at the Atlanto occipital joint and 35 degrees flexion at the level of C6, C7. And by placing the bed, it is in line with the acromion process, and also the external auditory meatus is in line with the sternal notch. And here you can see the glabella and the chin laterally aligned. So here when you place a headrest, 3 things fall in place. One is the acromion process and your headrest, your external auditory meatus and the suprasternal notch, and your chin and the glabella. These 3 things should be falling in the line when you place a headrest. And now coming to the 3 axes, pharyngeal axis, laryngeal axis and the oral axis. Okay. In neutral position, here you can see the oral axis, this is the pharyngeal axis and laryngeal axis. All are not meeting in line. This should be falling in line for the airway to secure. This is the neutral position where the axes do not align each other. Now coming to flexion, you just flex the neck. What happens if you flex the neck? Okay, due to flexion the head is elevated. Although the pharyngeal and laryngeal axis are aligning little bit, the oral axis is not aligning here. Again, here with only flexion, it is going to be difficult. You are giving just neck flexion, okay, and the axes are not aligning. The oral axis is not aligning with the pharyngeal and the laryngeal axis. Now let us see what happens if you give only head extension. Your head is extended. Here the pharyngeal and laryngeal axis may be in line, but look at the oral axis. It cuts perpendicularly with head extension. Again, here you can see the oral axis, but the pharyngeal and laryngeal axis are in line. It is going to be very difficult to secure the airway. So with flexion alone, the axis is not aligned. With extension alone, it is not aligned, and neutral axis also it is not aligned. That is the reason you go with the sniffing position, where you do 35 degrees neck flexion and a 15 degrees extension. Now you can see all the 3 axes are aligned together, pharyngeal, laryngeal and the oral axis. This is called the sniffing position, and here you can see all 3 aligned together, and it is easy for you to secure the airway. This is the logic behind doing the sniffing position. Now another, instead of pharyngeal and laryngeal axis, we look at what is called the primary curve and secondary curve. Primary curve is between the tongue and the glottis, and the secondary curve is between the glottis and trachea. In neutral position, here you can see how the primary and secondary curve. As you assume the sniffing portion, you can see the primary and secondary curve are aligned together. That is the reason you go for sniffing portion. This is regarding with the primary and secondary curve. So you can take the sniffing portion with regard to oral, pharyngeal and laryngeal axis, or with the primary and secondary curve. Now coming to the upper lip bite test, where you bite the upper lip with the lower incisor. You protrude the lower jaw or bite the upper lip. Assess the ability of placing the lower incisor over the upper lip. It is graded A, B and C. In grade A, what happens is your long incisor can be protruded anterior to the upper incisor. That is grade A. In grade B, the lower incisor is brought edge to edge with the upper incisor, and in grade C, the lower incisor cannot be brought edge to edge over the upper incisor. Here, the upper incisor is anterior to the lower incisor. Here, they meet each other. Upper and the lower incisor meet each other. Here, the lower incisor can be protruded anteriorly to the upper incisor. That is grade A, B and C. It predicts the ability to subluxate the mandible during laryngoscopy. This is called the jaw protrusion test also. Limited ability to protrude the jaw predict difficult laryngoscopy as well as bag mask ventilation. Now coming to the most important airway examination which you do in the preoperative period, that is Mallampati classification. It relates the size of the tongue to visualization of the oral cavity. The more the tongue obstructs the view of pharyngeal structure, more difficult is the airway. You have 4 classes in Mallampati. Class 1 is you can view the entire palatal arch including bilateral partial fillers which is visible down to the base. Class 2, the upper part of the partial pillar and most of the fibula are visible. Class 3, only hard and soft palate is visible, and class 4, only hard palate is visible. So in class 1, you can see the hard palate, soft palate, you can see the fauces, you can see entire uvula and full of tonsillar pillar. 100% tonsillar pillar will be visible in class 1. Coming to class 2, the tongue is bigger, the hard palate is visible, the soft palate is visible, your fauces can be seen, 50% of the tonsillar pillar can be seen, and the uvula also is visible. This is class 2. Now coming to class 3, as the tongue enlarges, the hard palate is visible, the soft palate is visible, only the base of uvula is visible in class 3. Class 4, only the hard palate is visible. This is Mallampati classification. With class 1 and 2, it is usually associated with easy intubation. With class 3 and 4, it is difficult intubation. So, you should always assess the Mallampati and document the class of Mallampati in your pre-op assessment chart. Now, coming to difficult airway assessment. You have a beard, it is going to be difficult airway assessment. Obesity, patient having large neck pad of fat and obese, edentulous, no teeth, elderly population and history of snoring, neck pad of fat. Coming to difficult intubation, which is called the Lemon scoring. L is for look externally, E for evaluate the 3-3-2 rule, M for Mallampati, and O for obstruction in the airway, and N for neck mobility. Coming to look externally, you look externally for facial trauma, large incisor, bird or mustache, large tongue and abnormal anatomy. Evaluate the 3-3-2 rule. Interincisor 3-finger breadth, iod mentor distance 3-finger breadth, and thyroid distance 2-finger breadth. Mallampati scoring, you visualize the tonsil, uvula and compare it with the tongue. Class 3 and 4 indicates more difficult airway. Coming to obstruction, upper airway obstruction usually presents with stridor, and neck mobility. Any limitation in neck mobility due to neck collar can affect intubation. Coming to Wilson scoring, which predicts a difficult intubation. Here you have 5 parameters and each parameter are given a score of 0, 1 and 2. First is weight. If it is less than 90 kgs, it is 0. Between 90 to 110, it is 1. And greater than 110 kgs, it is score 2. And head and neck movement, if it is greater than 90 degrees, it is 0. About 90, it is 1. If it is less than 90, it is score 2. Coming to jaw movement, the inter-incisor distance greater than 5 and subluxation greater than 0. If the inter-incisor gap is less than 5 cm or the subluxation is equal to 0, it is score 1. If the inter-incisor gap is less than 5 cm and the subluxation is less than 0, that means your lower incisor does not reach upper incisor. Lower incisor is behind the upper incisor. That means the subluxation is less than 0, where you are going to have difficult intubation. Receding mandible, none, it is 0. Moderate is score 1 and score 2 in severe, that you should see from the side angle. And buck teeth, if it is not there, it is 0. If it is present, moderate, it is score 1. It is severe buck tooth, it is score 2. Anything which is above score of greater than 5, difficult intubation and Wilson scoring. Now coming to difficult bag mask ventilation, which is formed by a acronym BONES. B for bird, O for obesity, N for edentulous, that is no teeth, E for elderly, and S for sleep apnea or snoring. Coming to difficult bag mask ventilation in another format, here you look for sleep apnea, that is snoring, bird, neck radiation changes in the neck, presence of male sex, Mallampati, score 3-4. Another predictor of difficult bag ventilation is elderly population, body mass index of greater than 26 to 30 kg per meter squared, edentulous, absence of teeth, presence of beard, history of snoring, Mallampati, class 3 or 4. Severely limited mandible protrusion. Clinical parameters for difficult bag mask ventilation: increase neck circumference or presence of buccal pad of fat, face and neck deformities, prior surgery, prior radiation, prior trauma or congenital abnormalities, rheumatoid arthritis, you might have a stiff neck, trisomy 21 where you have high palate archet and a large tongue will be there, scleroderma, cervical spine disease and previous cervical spine surgery. Coming to difficult placement of laryngeal mask airway, which is formed by an acronym of RODS, which is restricted mouth opening R, obstruction for O, dilated airway for D, and S for stiff lung as well as cervical spine. Difficult surgical airway is given by the acronym SHORT, which is airway surgery, hematoma, obesity, radiation distortion or other deformity, and T for tumor. Coming to difficult airway instrumentation, where it is difficult to pass the airway equipment with nose, the presence of polyp, a nasal clot, septal deviation or epistaxis, restricted mouth opening, presence of barrel chest, breast, pregnancy, limited neck extension and retrognathia. These are all the various airway anomalies which is difficult to pass the airway equipment. Coming to technology, there is continuous evaluation of technology and it also helped in the airway assessment as well as securing the airway. Ultrasound is the topmost technology which is used for airway now. It is a promising tool for assessing the airway. It is non-invasive real-time imaging of the airway anatomy and it can predict difficult intubation. Video laryngoscopy improved direct visualization of airway, thus enhancing the intubation success rate. Coming to airway ultrasound, upper airway focus and main function. First, you look at the suprahyoid where it is used for oral space assessment. 2, you look at the thyrohyoid which is epiglottis identification. Next is thyroid which is used for vocal cord function. 4th is the cricothyroid membrane identification. And finally, you have the suprasternal which goes for endotracheal tube confirmation. These are all the 5-point checks for ultrasound of the airway. Coming to technology, airway intelligence and machine learning being used in airway assessment. Machine learning algorithm can integrate multiple patient variables, offering more accurate prediction than traditional assessment method. So it has become more predictable and more accurate. Awake transnasal flexible video endoscopy improve preoperative airway risk stratification. Now coming to Cormack Lehane, which can be documented in case of previous anesthesia in the chart. Grade 1 is full view of glottis. Grade 2A is partial view of glottis. Grade 2B is only the posterior extremity of the glottis is seen, or only arytenoid cartilage is seen. Grade 3 is only epiglottis seen, but none of glottis is seen. Grade 4 is neither glottis or epiglottis is seen. And intubation is going to be difficult when it is greater than grade 2B. Here you pass the laryngoscope and you can deviate the tongue. In grade 1, you have a full view of the glottis. In grade 2, you have partial view of the glottis and the arytenoids. Grade 3, view only the epiglottis, and in grade 4, neither glottis nor epiglottis is visible. Now coming to the investigation which is required for airway assessment, you can do a nasal endoscopy to assess the nasal patency, awake laryngoscopy again to visualize the cord movement and as well as the entire glottis, whether the glottis is visible or not. You can look at the movement of vocal cord, lateral neck X-ray, chest X-ray, CT and MRI for the various anatomical deformities of the airway, and not to forget the ultrasound of airway. So to summarize the airway examination, the first and foremost is the mouth opening. You look whether it is less than 4 cm or greater than 4 cm. You look at the thyromental distance. If it is going to be less than 6 cm, it is difficult, and greater than 6.5 cm is normal. Next, you look at the Mallampati classification. It is going to be difficult with grade 3 or 4. Then you look at the neck mobility. It is normally greater than 90 degrees. Between 80 to 90 degrees, it is equivocal. If it is less than 80 degrees, it is going to be difficult. Neck circumference. More the circumference, more difficulty with laryngoscopy. You look at the jaw protrusion test. If jaw protrusion, your lower incisor is anterior to the upper incisor, it is normal. If it is not, if it is meeting or it is posterior to the upper incisor, the intubation is going to be difficult. Now coming to various examination component and non-reassuring finding, you look at the length of upper incisor. If it is going to be protruding and long, it is going to be difficult laryngoscopy. Then the relationship between the mandible and maxillary incisor during normal jaw closure. If there is prominent overbite, that is maxillary incisor anterior to the mandible incisor, that is a non-reassuring finding. And relationship of mandible and maxillary incisor during voluntary protrusion, that is jaw protrusion. If mandibular incisor at the level of maxillary incisor, again laryngoscopy is going to be difficult. Inter-incisor distance, if it is less than 3 cm, that is mouth opening less than 3 cm, is a non-reassuring finding. Visibility of uvula. If the uvula is not visible when the tongue is protruded, that is Mallampati 3 or 4, intubation is going to be difficult. Coming to shape of palate, highly arched or very narrow, it is going to be difficult airway. Compliance of the mandibular space. If the mandibular space is stiff, indurated and occupied by mass or non-resilient, your airway management is difficult. Thyromental distance less than 3 finger breadth is a non-reassuring finding. If the length of neck is short or the circumference is more and it is thick, it is a non-reassuring finding. And coming to the range of motion of the head and neck, patient cannot touch the tip of the chin to the chest or cannot extend the neck. Those are all non-reassuring finding. Sharp protruding incisor or edentulous is a non-reassuring finding, and presence of beard and edentulous is a non-reassuring finding. So to conclude, airway assessment tool can help to predict the difficulty or ease of intubation. The multi-dimensional approach of airway assessment required an individual approach for each patient. Airway assessment requires clinical judgment, physical examination and innovative technology. While traditional examination plays a vital role, newer techniques such as ultrasound, video laryngoscopy along with artificial driven method may offer improved accuracy and efficiency. So to conclude with a short summary of the airway assessment, you look at the conscious level, you look at the nasal patency, go for the oral access, all the 4 quadrants should be accessed. You look at the dentition, speech, swallowing, breath sounds. Look at the mandibular pathology and soft tissue pathology, front of neck axis. You look at the temporomandibular joint and also the cranicocervical junction, cervical spine. Look at the Mallampati classification, mouth opening, mandibular protrusion, upper lip, bite test, thyromental distance and cervical spine movement. Thank you.